on the LowDOWN, a Dancing Doom podcast. Dr. Ken Nischal gives us the lowdown on vision and Dancing Doom. Over to you, Hannah and Marilla.
Thanks, Jody. Hello and welcome to the Lowdown. I'm your host, Marla Folden, and I'm an SLP here at the Down Syndrome Resource Foundation. I'm joined by my co-host, Hina Mahmood, who's OT at the DSRF. Hi, Hina.
Hi, Marla. How are you?
Ooh, I'm doing well. Very caffeinated at this point. So,
yeah, I know it's an afternoon. It's an afternoon post-lunch recording, so caffeine is required for sure.
I'm ready. Before we continue on with our episode, we would love for you to hit the subscribe button and leave a review of our podcast on your chosen platform. Remember to check our episode pages for additional resources related to each topic, and you can follow us pretty much everywhere. We've got a website, and we're on Instagram and Twitter as well by following at DSRF Canada. On today's episode, we're going to explore a topic that I feel like probably doesn't get as much attention as it should when we're considering the Down syndrome population, and that's vision. So how we see can impact almost everything that we do all day long, from our day-to-day routines. And if there's any challenges with vision, it makes everything difficult. And Down syndrome does have effects on the developing eye, which can impact the proper development of vision. Eye disease is reported in over half of individuals with Down syndrome, ranging from less severe to more vision-threatening diagnoses. And we will get right into it in this episode.
Yeah, so I'm really excited to welcome our guest today. So born in Nairobi, Kenya, and having grown up outside London, UK in Slough, Dr. Nischal had gained his medical degree from King's College Hospital at the London University, trained in ophthalmology at the Oxford Eye Hospital Rotation, fellowship in pediatric ophthalmology and strabismus at Hospital for Sick Children in Toronto, appointed as a consultant at the Great Ormond Hospital for Children in London. And he then was recruited to Pittsburgh in 2011 and is now the Division Chief of Pediatric Ophthalmology and Strabismus at the UPMC Children's Hospital of Pittsburgh, Medical Director of Digital Health. Welcome, Dr. Nischal, to the Lowdown. Thank you so much for joining us.
Well, thank you for inviting me.
Our pleasure.
Yeah,
our pleasure.
Mm-hmm. Yeah, so we're very excited. This is a topic that I've always had a bit of interest in because I think it's just something that kind of always gets pushed aside from some of the other medical challenges that our individuals with Down syndrome experience. So I feel like it's a really important thing for our listeners to learn about. But before we dive into all that, we were wondering if you could indulge us in answering some of our secret questions.
Absolutely.
Perfect. Okay, so I'll start off. If you were to compete in either the Winter or Summer Olympics, what sport would you choose to compete in?
It would be the bobsled in the Winter Olympics, because I love the movie Cool Runnings. Yeah. And if they can do it, I can do it.
Yes.
And I just want to be able to say, as I roll over on my bobsled, Sanka, you dead? Nah, man.
I saw that Jamaica has a team for bobsled this year for the Olympics. I got very excited.
Very excited, yeah. I love that you have thought about this question before and you had an answer right away. I love it.
Well, no, I didn't. I just know that that's what I want to do. It's my secret desire.
Love it. Okay, question number 2. What is your favorite breakfast food?
Oh, that's easy. I make a smoothie every day myself. Okay. And it has kale and spinach. Mm. It has carrots, half a lemon. It has blackberries, some water, and some ginger in it, fresh ginger.
Oh, yes. You have
that is. I absolutely. And then sometimes, if I'm feeling decadent, I'll stick a banana in as well.
I like how your definition of decadency is banana. I love it. I'd be
no, it's much more than that. But I'm like
chocolate powder.
But that's my daily healthy breakfast. But if I was with my daughter in DC, she works there, and she took me to a place which was amazing, and I had eggs Benedict with salmon, and that was wonderful.
Oh, yeah. Now you're talking my language.
Oh yes, absolutely. Mm-hmm. We wrote these questions when we thought the pandemic was going to be done. So I'm laughing at this. As we get through this wave of the pandemic, where would you like to go on vacation if it were an option?
Well, it's funny you should say that. In the last 6 months, I have been to about 6 countries outside the USA. So I have traveled. I mean, my nose doesn't know what's happening to it because it gets swabbed so often. So where would I like to go on vacation? I would like to go to the Isle of Islay in Scotland because I like single malt whiskies.
Oh.
And I'd like to go spend 4 days around the distilleries pairing single malts with chocolate because that's what they do. They give you wine, they give you malt tastings with paired chocolate.
That does sound decadent. I mean, yes. And quite a trip.
You're impressed at how quickly I'm giving you the answers, aren't you?
I can tell
I know, we didn't even. Exactly. We didn't even send you these questions. Love it though.
Question number 4. If you could instantly be an expert in something you don't know anything about, what would you choose as a new topic of expertise?
Artificial intelligence. I wish I could program for artificial intelligence because I think that doctors of the future will need to be coders as well.
Oh, interesting.
I bet you're not wrong. I was just thinking of all of the surgery robots that I know of, and I'm like, oh, yeah. That's true. Okay.
Yeah, very interesting. Yeah, I mean, I think it's going towards more technology reliance. So why, instead of fighting it, maybe just join.
Be good at it.
So I think the thing is, why I say doctors of the future, the best doctors are going to be coders, is that they will come across a problem, and if they can code a computer program to evaluate the data faster than the human brain can, which is being done now, they'll be able to deliver innovation much faster than we're doing at the moment. Because at the moment, if I have an idea, I have to go and find a student, I have to go and try and work with a postdoc, and they don't have the money, I have to find research funding. Whereas if I could code and I understood, I think it's called Python. I don't know, Python or Pythagoras. What's it called?
Python. It's called Python.
If I could use that and I knew how to do it, I'm sure I could get to the answers quicker. So anyway, that's
postdocs.
Very interesting.
I mean,
there you go.
Skip them.
Yeah, I like that. It's a very interesting way to look at it for sure. Okay, so our last question is: you're, I'm sure, very, very busy in your day-to-day routine. What do you do to de-stress?
So apart from exercise, which I don't do every day, I should do every day, but I don't do every day. Apart from exercise, which really helps me de-stress, I enjoy really watching foreign movies. I love foreign movies because when you watch a foreign movie, you're stimulating certain parts of your parietal lobes that don't get stimulated normally. And I enjoy that, and I love listening to foreign music. So that's what I do.
Any region in particular?
So foreign music, African. I love West African music, Mali, Senegal, Cote d'Ivoire. Yeah. There's a guy called Salif Keita who actually he was born an albino, and in that culture, albinos are considered not nice individuals. So he was thrown out by his family, picked up by troubadours, and has become one of the highest selling artists in the world. If you ever get a chance to listen to his music, Salif Keita, Keita, it is phenomenal. His voice is phenomenal.
Ooh, wonderful. I lived in Ghana for a brief moment, and the music was everywhere. It's integrated into every part of life, and it is on high volume. So,
years ago, I went to Dhaka, and that was at every street corner you had music, and they were creating music from instruments that weren't really even instruments.
Creative. Yeah, it's spectacular.
Yeah. Great. Well, thank you so much for kind of playing along with us on that. I learned a lot, and actually you've kind of made me want to now, research Python, AI, and surgery, and some amazing West African music. So that's great. So let's kind of dive into our episode. Can you tell us a little bit about your experience in working with individuals who have Down syndrome?
Yeah, so as a pediatric ophthalmologist, I've been working with patients who have Down syndrome since 1992. More recently, I've been seeing more and more adolescents and adults being referred to me from around the country because of a particular condition called keratoconus, which I'm sure we'll get a chance to talk about, because there is this treatment called collagen cross-linking, which is available. But many, many patients with Down syndrome don't have the level of cooperation needed to have that treatment done in the standard way, which is awake under local anesthetic, lying on your back for 1 hour. So we at Children's Hospital of Pittsburgh give them a general anesthetic, no matter what their weight, no matter what their age. I'm very lucky that the hospital supports this for patients with Down syndrome who have special needs. And so that my involvement with them has become greater in the last few years. Prior to that, it was basically screening for ocular problems, which we know occur at a greater rate than the normal population. And there's a whole range of them, which I'm sure we'll
get
cover.
into. Yes.
Yeah. And I think it's so great that your experience is mainly as a pediatric ophthalmologist, but because you are working a little bit more with adults, it's nice to kind of have that bookend of experience where you can kind of see how their vision is developing over the lifespan. So I think that will just make our discussion that much more richer. For our listeners, can you please explain the difference between an ophthalmologist and an optometrist? Because I know that those terms get switched up quite a bit.
So look, I think the first thing to say is ophthalmologists and optometrists have the same goal, and that is to maximize the potential of the vision of the patients that they're seeing. And the same goal is to treat any conditions that might prevent that from happening. Optometrists have their own course of optometry and their own American Academy of Optometry in the USA. Ophthalmologists have to do a medical degree or a degree of osteopathy before they then do residency for 3 years in ophthalmology. And then to be a pediatric ophthalmologist, you have to do another year, at least 1 year of clinical fellowship in pediatric ophthalmology. So the difference also is that ophthalmologists can operate surgically. Optometrists, by and large, can't. But the evaluation and treatment is very similar between the two. But what the treatments an ophthalmologist can do is has a greater range because it includes surgery.
Yeah, very well put. And the reason why I asked that is because, in the Down syndrome healthcare guidelines, they do mention that regular checkups with an ophthalmologist, and they say that specifically, is very important. So I know that in my day-to-day interactions with families, a lot of parents will say, oh yeah, we've seen an optometrist, but just kind of getting them to understand that sometimes optometrists might be looking for different things than an ophthalmologist would be, even though their end goal is still the same, is to help develop vision.
So to give you, I understand what you're saying, and I know what the guidelines say. I'll go back to the fact that both optometrists and ophthalmologists have the same goal, and I think that the best way to make sure that both groups are assessing children with Down syndrome the best is to have communication. So in Western Pennsylvania, in Allegheny County, where we are based, we've developed a pediatric eye network, which is a number of local optometrists in the community who meet with us virtually on a regular basis, and we develop common protocols. And we haven't covered Down syndrome, but that to me is an excellent one to do next, so that we're all doing the same thing and checking the same thing when we see them. The reason why I say that is that what we have to make sure that the best form of medicine is medicine that's accessible. And if parents are living somewhere where it takes them 3 hours to get to an ophthalmologist, but half an hour to get to an optometrist, I would like that accessibility to be available to the parents. I wouldn't like to say to them, well, you can't see an optometrist, you have to see an ophthalmologist. And they find they can't get there, you know? So
Yes.
that's my attitude to that issue.
Oh, it makes a lot of sense. And here in Canada, I mean, we have a space issue, right? That specialist might be a flight away in a lot of cases. So it would be ideal if everyone were doing the same protocol and following the same guidelines. And we would love to, I think, develop some more of those patterns of referral in Canada.
Yeah, and I think
that your network.
Yeah. It's not difficult. I don't think it is. We managed to do it here in the USA, certainly in Pennsylvania, Western Pennsylvania.
Mm-hmm.
Yeah. Great. So why is it important to, as per the healthcare guidelines, why is it important to do these checkups during the early years of development?
And so that's a very, very important thing, and I would have mentioned it had you not asked me. When a baby is born, regardless of what their status is systemically, between the ages of 0 and 8 years, they learn to see. So they can't see. When the baby's born, it can't see. Everything's just a blur. And the brain then develops the ability to process images and to see. If you have something, and the brain has an innate sense of what is normal. And so if you have something that disrupts that, and the commonest things are a high refractive error, in other words, the need for glasses, or nystagmus, that's when the eyes are not still, or strabismus, that's when one eye is turning in or turning out. Mm-hmm. The brain stops taking images normally, and it starts to lay down that abnormal image into the seeing part of the brain called the occipital cortex. Mm-hmm. And if that happens and it's not corrected, by the time you're 8 years, this neural plasticity that exists disappears, and now what you have for the rest of your life. You can do any fancy operations, any fancy contact lenses, but if the brain has a limited ability to process images because of disruption in the early years, then you're done.
Mm-hmm. Oof, I got nauseous just thinking about it.
Yeah.
so that's called that loss of vision because of an abnormal visual experience is called amblyopia. Now, if you have one eye that's turning in, the brain realizes it's seeing two images because one eye is pointing one way and the other one the other way, or in another direction. And so the brain stops taking images from the eye that it innately knows. It says, well, I'm looking at Marla's face and I can see Hina's face, but I'm going to ignore the Hina's face because I want to look at Marla's face, or the other way around. So that is another reason for the development of amblyopia. Now, in children with Down syndrome, there's an added complication. That added complication, actually, it was Margaret Woodhouse who brought this out. Margaret Woodhouse is an optometrist in Wales. I think she's in Cardiff University. She may have retired now, I'm not sure. That woman is amazing, single-handedly changed how we looked at children with Down syndrome because she showed that a significant proportion of children, not a majority necessarily, but a significant proportion of children with Down syndrome are not able to focus properly for near. Now, you know that as you accumulate birthdays, and I've accumulated enough birthdays, I'm now wearing bifocals because I can't focus for near. And so these children have that lack of ability to focus. And if you think about it, in the first 4 to 5 years of life, your world really is about an arm length away. And if you can't focus, you can't see. So you see blurred. And the problem is that this affects their reading, it affects their fine motor skills, because if you can't see to pour water from one glass to another because it's blurry, you're going to miss the glass, right?
Yeah.
It also causes the eyes to turn in, because if you overfocus, your eyes will turn in. And that's what happens. They try to squeeze the focusing out. And as a consequence, there's a turning in of the eye.
I wanted to ask you a little bit about the plasticity.
Yeah.
So we know that our students with Down syndrome, children with Down syndrome, they all experience a developmental delay. So they're not meeting the milestones at the same rate as other children would necessarily. But is the plasticity still set by age 8? So no matter where you are developmentally by age 8, it's over?
The answer to that question is nobody knows. Nobody knows. What I will say to you while we're on this subject of plasticity, that again, Margaret Woodhouse recently did a paper where they used a questionnaire to assess whether a child may have cortical visual impairment, and they were only Down syndrome patients. Cortical visual impairment is interesting. It doesn't mean that the visual cortex necessarily is affected, but what it means is that the processing of images. So you get an image in the visual cortex at the back of your head. The parietal cortex now processes that and then tells the brain what's going on. The brain makes sense of it and acts accordingly. But one of the things about CVI is, and this really didn't occur to me until I read this paper, is some Down syndrome patients that I see get very agitated the more people there are in the room when they're being examined. And they don't like crowding. Crowded pictures or crowded scenarios agitate them. They can't think straight. They might be calm normally, and now they become agitated. So this is a sign of the inability to process all those multiple sensory visual inputs and make sense of them. So there's in the paper she wrote, she found that up to 38% of patients with Down syndrome had some evidence of cortical visual impairment. And I don't think that that's generally acknowledged.
Yep.
No.
So happy you said that.
Yes.
Yeah.
And I think it's often written off as overwhelm. Oh, they're overwhelmed. Yeah. But not why.
Or they're not
overwhelmed.
Yeah. Or they're being stubborn. They're not listening. They don't want to look. They don't want to do this. And I'm so happy you brought up the cortical visual impairment, because in my line of work as well, I try to get families to understand the difference between, visual issues like a refractive error or a strabismus, like an anatomical issue or physiological issue, versus the processing of the information in the brain. Because there is lots of research out there on how it's so difficult for our individuals with Down syndrome to, in global organization, visual discrimination, all those things that you mentioned are a separate issue as well that needs to be addressed.
Absolutely. And I mean, some people say that we shouldn't use the term cortical visual impairment. We should use the word cerebral visual impairment to acknowledge or convey that it's a global processing issue, right? And we know that if you look at the volume of the brain in patients with Down syndrome, it's somewhat reduced. So we know that there is anatomical substrate to suggest that there may not be the normal setup of processing.
Yeah, absolutely. So this kind of leads us into our next question. So we're kind of touching on it, but let's talk a little bit more about some of the signs and symptoms that might indicate that there's an issue with vision for individuals with Down syndrome.
Yeah. So I think look, to do that effectively, it's probably worth just running through from the front of the eye to the back of the eye as to the problems that can occur, and then how a child may present with those, right?
Sure.
So,
Great.
And I'll talk about visually insignificant changes as well as visually significant. So if you start at the front of the eye, if you've got your eyes closed, then you see the lids, right? And in the lids, in children with Down syndrome, there's a higher proportion who have a blocked nasolacrimal duct, and that presents with watering eyes. Now, sometimes it's partial, and the watering eye only occurs when they go out in the cold. But a watering eye and overflowing of the tears down the cheeks is a sign that they could have a nasolacrimal duct obstruction. Now, the reason why it's important to get that fixed is that if that gets infected, you've got nowhere for the bugs to drain, and then they just grow in the sac of the tear sac, and that can cause a nasty infection. The lids, the older the child gets, and they don't have to be that old. I saw a 6-year-old girl with Down syndrome who had terrible, terrible blepharitis. Blepharitis means inflammation of the lid margins, but in particular, these children get meibomian gland dysfunction. So let me explain what that is.
Please do.
Yeah.
In the lid margins, there are lashes, and behind the lashes is a row of glands that produce oil. The oil goes on top of the tear film to stop it evaporating too quickly. If those glands get blocked, they're blocked with fatty, rich material. The normal bacteria that live on our skin overgrow. They incite an immune reaction from the body, and so the lids get red, they get puffy, and they can get infected. But they can also just be chronically irritated, and then you get dry eyes. So what happens, these children are eye rubbers. They rub their eyes, they blink a lot. I mean, it's like when I see a child with Down syndrome, and I often see this on the television, if they're with their parents, I know you can't see this, but they're doing this as they're talking. I want to sort of send a message and say, will you please get them to an eye care professional to see if they've got dry eyes secondary to meibomian gland dysfunction. Now, the older they get, the problem is they can get ulcers on the cornea. They can also get them when they're younger, but the older they get, that the immune response can result in an ulcer of the cornea. So if you've got a child now who's blinking a lot, that's one thing, is an eye rubber. That's something that means that they need to be looked at.
And parents might also notice a buildup of like the fatty substance in the eyelashes, right? I see
the eyelashes. Yeah, that's sort of a seborrheic. Yes, but they can. And sometimes one of the glands will get so blocked that they'll get a little lump called a chalazion in the lid. And that's another sign that they've got meibomian gland disease, and they need treatment for that. You know, they need drops and they need warm compresses. Going back then on the iris, which is the colored part of the eye, many children with Down syndrome get something called brush field spots. These are just pigmentation. It's a light pigmentation. It's not visually significant. And you can see it in up to 11 to 12% of patients who don't have Down syndrome. So it's not significant. One thing that is significant is the cornea. If you're an eye rubber, and we don't really know the etiology, what we know is that the prevalence of keratoconus, that's when the cornea, instead of being like a sphere, becomes like a cone. The problem is, as it becomes more acutely conic, you can get a rupture and you get scarring, and that affects your vision.
Yeah.
You know, you can't see.
So do you suspect that is related to interference with the eye, chronic eye rubbing? And some of those things?
So it's well established that chronic eye rubbing can cause keratoconus. People, you know, it's difficult to know for sure, right? But the prevalence of keratoconus in the general population is 0.2 to 0.4%. But in Down syndrome, there's a really good paper from somewhere in, I think it's Denmark, or it may have been Sweden. They found it was 5.5%. So that's a significant increase compared to the normal population. So how would you know? Look, you'd know if they develop what we call high drops. That's when they get the rupture, because it's incredibly painful. The child's got their eyes shut, or the teenager, or even the adult, because of the pain. And of course, that needs an emergency room visit. When you look at the lens, children with Down syndrome or adults with Down syndrome often have what we call blue dot cataracts. They're not visually significant, but they can become significant if they coalesce and they become a proper cataract. And how would you know? You'd see a change in behavior of the child. In the adult, they'll tell you that they can't see, or they're not seeing things, or they're missing things. But in the child, there's a change in behavior because they can't see. And so, again, that needs fairly urgent attention.
Is that something that develops as the child grows, or is that?
Yes, so you can get a child with Down syndrome have cataracts at birth, which is normally picked up on screening, but usually it develops as they grow older.
Okay.
So cornea, right. So the other one that is important is the discs, the optic discs. We don't think they're visually significant, but they have a large number of optic disc anomalies, and those optic disc anomalies are, increased number of disc vessels crossings, slightly smaller discs. Those are the main things, but again, not necessarily a parent wouldn't pick anything up. It wouldn't be that way. But then you look at, and we've talked about cortical visual impairment. We've talked about the things like processing, overcrowding, being told that's a cat, and then not recognizing it's a cat just a minute later, something like that. So that, now the problem is getting someone to assess that is not easy. It's not easy. And you often want to go to an educator, teacher for the visually impaired. They may have a better chance of doing that than a physician. So it's something to be aware of, but I may be doing a disservice to optometrists and ophthalmologists who understand this better than I do. So always mention it, if you notice those patterns. A high refractive error is children either not being able to see stuff in the distance, that means they're nearsighted, or having hyperopia, which means that they can't see stuff from near, and if they're under accommodating, you'll see the eyes turn in. And of course, nystagmus. Most children with Down syndrome and adults with Down syndrome get nystagmus from birth. That is 6 weeks after birth. That's when it develops. And they don't, their vision may be reduced slightly because of it, but what the parents are seeing is the eyes wobbling. And again, if they wobble, then they need to be seen. Older children, especially teenagers, who are having difficulty recognizing things close up or having difficulty reading. I've heard teachers send me patients who say, this Down syndrome patient is functioning at a fairly high level, but we have issues with reading, which don't make any sense. And you find that they're under accommodating, under focusing. You give them reading glasses and you see this amazing uplift in their reading performance. So I think all of those things, if a child, I have some parents who burst into tears because when you give them glasses for near, the child can do things. Until then, parents have been told that the child was clumsy. And they're not clumsy, they just can't see for near. So you need to be able to assess the accommodation. It's called a dynamic retinoscopy is what you need to do. And these are things that should be done. And they're done before you put drops into a child's eyes or an adult's eyes.
So is this what an optometrist or an ophthalmologist would say to a lay person as taking the measurements? Is that what this is?
Yeah, but I would say to you that taking the measurements are often done in children with Down syndrome after you've put dilating drops in them. You need to take this measurement before you put the dilating drop to assess their accommodation.
Okay. I mean, this is important. This is really important to know.
Yeah. And so there's a few things that I kind of want to unpack here. So you were talking about refractive error. So let's start talking about what are some of these vision issues? Because we do see a lot of our students with glasses. It's like a very common thing. So of the list of things that you talked about, which of those are an indication that they need glasses? If that makes sense.
So sometimes if a child has a refractive error early from age, you cannot pick up from their behavior that they need glasses, hence the need for regular screening. In fact, I think the guidelines are that they're supposed to be screened at 6 months and annually till 5 years, then every 2 years until they're 13, and then every 3 years thereafter for the rest of their life, unless they have a problem, in which case it should be done sooner. So the refractive error can be missed because the child copes.
Yeah.
I think sometimes too, parents wonder how in the world would somebody assess my kid's eyes? They don't talk.
Mhm.
Like, when you go for an eye test and they say A or B, A or B, A or B, and they're doing all of that. And so they don't take their children because they're like, well, how would that even work? What does that look like?
So I'm glad you asked that question. In children and in adults, you put a drop in their eye that paralyzes their focusing. Once that's done, you use an instrument called a retinoscope, which has that projects a streak of light, like a pen light, but it's in a streak. When you shine that in a dilated eye, the light goes through the cornea, through the pupil, through the lens, and it hits the retina and then bounces back. If you are moving the streak sort of vertical, right, back and forth, left to right, you see the reflection either moving in the same direction or moving in the opposite direction to your movement of your streak. If it's in the opposite direction, it means that the child is nearsighted, and you take minus lenses, put them in front of the eye until the reflection no longer moves in either direction. And at that point, you take away the distance at which you are working, normally 2/3 of a meter, so you take 1.5 units off, and that tells you the power of the eye for the glasses.
Okay, well, this is the coolest thing I've heard all day.
I know.
This is
I was
excellent.
just going to say, that's how it works. Great.
And then,
so that means that the child doesn't necessarily need to cooperate beyond being able to be in a chair.
Yeah. Well, some children won't open their eyes, and that can be a problem. But here's what I say. I always say to parents with Down syndrome, if after the second visit I still haven't been able to get anywhere because they're not coping, I will have had an idea of whether they got a refractive error or not. And I say, look, the child's going to be put to sleep for anything like teeth or anything else. I'd like to get involved and do an eye exam. And if they're not, I think a short eye exam under anesthesia, but with people who know how to put children with Down syndrome to sleep, is so worth making sure that they get the full visual potential.
Mm-hmm. Yeah, very helpful. Yeah. Dr. Nischal, you had alluded to a couple of other common conditions. Can you just talk a little bit about strabismus first and what that is? Yeah.
So a lot of strabismus seen in Down syndrome is accommodative. That means it's related to the fact that they can't focus or that they're over-focusing. Mm-hmm. And when you give them the appropriate glasses, sometimes they need to have bifocals. That means those are the bifocals you see elderly patients wearing. Mm-hmm. You've got a script for the distance, and then you've got an additional script in the lower half of the lens. The eyes will often just go straight because you're now taking away the impetus. However, there's also a significant minority that even with the glasses, there's still a remaining residual esotropia. Now, that's when the eyes turn in, esotropia. If the child's vision is equal in both eyes, and over a period of, let's say, 3 visits or 2 visits, that deviation remains stable and the glasses power doesn't change, then you may have to operate on them to straighten the eyes. And you're doing that to afford them the opportunity, not the absolute realization, but the opportunity of using the 2 eyes together. And I say that because sometimes the way the processing of information is affected in children with Down syndrome, they do not have the ability to fuse 2 images. Right now, I'm seeing one of you because on the screen, because my brain can fuse the 2 images, the one from each eye, into one. And if you can't do that, then you get double vision. And the brain sometimes will induce a strabismus so that it can ignore the other image. In other words, if you've got eyes that are straight, but you can't fuse, you're forever seeing shadowy objects or 2 images. And that's difficult. So the brain says, I'm pushing this eye back to where it was. Mm-hmm. I can then ignore that other image and concentrate on what I'm looking at.
Mm-hmm. Yeah. It's essentially like a misalignment of the eye, right?
Yes, sorry, yes. So it's misalignment of the eye.
Yeah, interesting. Okay. And then the other one I wanted to dig a little bit into is amblyopia. or lazy eye. Because I have a few of my clients that have severe amblyopia. So can you talk a little bit about what it is and how it would affect their, an activity that they would be doing?
So you remember that we talked about getting an abnormal visual experience during the first 8 years of life, and that could cause a drop in vision, and that's what amblyopia is.
Mm-hmm.
So when you see amblyopia, you have to try and treat it when it's in one eye by patching the good eye.
Mm-hmm.
And they don't like to be patched. Most children don't. Down syndrome children just want to rip that patch off. So you have to use drops, atropine eye drops, 1%, can be used to blur the good image and make the brain use the eye with the poorer image in the refractive error.
I would just want to make clear to people who are listening who might be horrified by this, this is a not forever.
No.
We're not doing it forever.
No. Yeah. You're doing it during the plasticity stage, right? And the closer you get to 8, the more likely you are, if the vision's improved, of tailing it off and stopping that.
Mm-hmm.
But there is no other treatment at the moment. Now, there are some newer treatments that have come along called dioptic stimulation, but those gadgets are expensive. And while the initial studies show some promise, patching is still the way to go at the moment.
Mm-hmm. Is that deep brain stimulation?
No. It's a way that basically they put glasses on and they see 2 images. One image has a filter in front of it over the good eye, so they can still see through it, but the contrast is reduced.
Oh.
And so they prefer to see with the eye that's got the better contrast, which is the eye of the amblyopia.
Mm-hmm.
Interesting. That's an interesting development.
And I think that even our students that are not very, amenable to wearing a patch, some don't even like the drops, so it's a tricky thing, but there are ways that we can get them used to wearing a patch, so there are behavioral interventions, and, your local occupational therapist could probably help, in helping them desensitize to these things, because in the case of my client, it's made a massive difference. And all of a sudden, I was just going to say, Dr. Nischal, what are some of the, because I think there's certain signs that may indicate amblyopia, like in terms of like maybe looking out the corner of your eye. Are there a few externalizing things that we could look for?
Yeah, so there aren't any external signs of amblyopia, but there are signs of the causes of amblyopia. So strabismus, children turning their head to look out the corner is often astigmatism. We didn't mention that. Astigmatism is when the shape of the eye, instead of being like a soccer ball, is like an American football. And so the power in the 2 meridia of the eyeball are not the same. And what I mean by meridia is, sort of vertically and horizontally. Sometimes it can be oblique, but vertically and horizontally, the power should be the same. If it's not, it means that there is astigmatism. And children will sort of look out the corner of their eyes to do that. Children will develop head postures if they have nystagmus, because they put the eyes in the position where there's no nystagmus, but in order to do that, they have to turn the head or lift the head or depress the chin, etc.
We see a lot of
the eyes and the nose are always misaligned. I have nystagmus, and my nose has to point one way, my eyes have to point another way in order for me to feel like centered. Otherwise, it's that's a very interesting experience for sure.
Mm-hmm.
Go ahead, Bart.
I was wondering if you could talk a little bit about idiopathic intracranial hypertension, and I will translate that briefly for people who don't work in medicine. In my mind, this is embarrassing to admit it, because I translate these things often, and in this one in particular is why pressure in the head, and that's what I use to cue myself.
Yeah, well, that's a good. So, idiopathic intracranial hypertension is when, so in the human brain, there is fluid called cerebrospinal fluid. It is there are 2 lateral ventricles or cavities, a 3rd ventricle and a 4th ventricle. And the way I describe it is, if those of you who have ever seen Star Trek, the USS Enterprise, if you think about the shape, the 2 things on the side are the lateral ventricles. the disc at the front is the third ventricle, and the body at the bottom is the fourth ventricle.
Perfect.
That's exactly what they look like.
That's so great.
And the purpose is to keep the brain refreshed and nutrients getting to the brain and take away toxic substances. And this CSF, and that's a sort of very, there's lots of other things the CSF does, but that's a good way of looking at it. The CSF then also goes and bathes the whole of the spinal cord all the way down your back. Now, if you have something that blocks that flow, it builds up in those ventricles and the pressure goes up. Now, that is not idiopathic. There's a cause, there's a blockage, whether that's due to stenosis or whether it's due to a tumor, there's a cause. In idiopathic, there is an overproduction of the fluid without any other sinister pathology. And we know that this condition occurs at a higher rate in patients who are overweight, females in the sort of middle ages, but also in children who are overweight. And of course, in Down syndrome, that's not uncommon. And also in Down syndrome, we know that they can get sleep apnea. An obstructive sleep apnea can be associated with idiopathic intracranial hypertension. The way you pick it up is a behavioral change if they can't communicate with you, or they tell you they've got headaches, or they're throwing up with the headaches. We have to do a scan to make sure there's nothing sinister. And then when you look in the optic nerves should look like lifesaver candies or polo mints. They're flat with a hole in the middle. It's not actually a hole, it's just a space where there's no nerve tissue. Well, instead of looking like that, they look like marshmallows because they're swollen. And you have to do something about this, because if you leave that as it is, the child will lose vision slowly and will lose visual field slowly.
And I think the prevalence for people with Down syndrome is somewhere between 3 and 4%. So it's not unheard of.
No.
And I believe there's also a link between hypothyroid treatment, so some of your Synthroid and some of those, and
yes, and also that can happen. And also if they're taking doxycycline for acne or blepharitis, it can happen with doxycycline. So yeah, there are known associations.
I think the major behavioral piece in my understanding is headaches, which in our student looks like banging your head probably on things, the floor, the walls, because how else do you communicate that it hurts a lot? And it's a nice distraction if you have a headache. So if you suddenly start seeing that or see that as a parent, go get seen.
Absolutely.
Yeah. Dr. Nischal, we know that our individuals with Down syndrome age at an accelerated rate. So how is that impacting their vision? Are they having some of the vision issues a person in their 40s would have earlier in their 20s?
No, not necessarily. I mean, so it depends what else is going on. If they're myopic, in other words, they're nearsighted and their eyeballs are very big, they can get myopic degeneration of the macula, which is the central seeing part of the eye, earlier than you would expect, but not normally in the 20s, maybe in 30s or 40s, because if this is going to happen, it normally happens in the 50s and 60s in the normal population. So I think that's probably the commonest thing that you might see. You don't tend to see, well, you can see cataracts by the time they're 30 or 40. They normally develop in the 50s or 60s in normal individuals. So there is that, but there isn't anything that I would say was sort of absolutely specific to Down syndrome.
Okay. That is good to know. Do you expect when someone comes to see you that you will be able to get 50-50 vision from them?
50-50, or you mean 20-20?
20-20. I'm thinking I've heard of cases recently where they were told not to expect anything better than 20-50. That's
I understand. I just wanted to make sure I wasn't missing out on a new trendy thing, So the answer is I don't expect them to have 20/20. I expect them to have 20/40 at the minimum.
Okay.
If they don't have 20/40, then I really go to town and figure out what I can do to get them better than 20/40.
Okay.
Or at 20/40.
Right. Okay. Do you have any tips for parents who have upcoming appointments and maybe they're worried about their children's vision? Any ideas for them on how to approach these kind of appointments?
I think it's a good idea to role play, to show them that, we're going to cover up one eye to measure the vision. This is how we're going to cover the eye up. So it's not a big shock when a child gets in.
Mm-hmm.
So a bit of role playing, explaining that they might need drops and what the drops feel like and what they're going to do and how they're going to help the child, that sort of stuff.
Mm-hmm. Practicing in advance is always
and maybe even just having a conversation. I know a lot of parents are just worried, like, will the ophthalmologist or optometrist know how to interact with my child? Because I've heard stories where parents are looking at them.
Those are all valid concerns, but I think if the parents know that the child something that the child doesn't like, if the child doesn't like sitting on their own on a chair, then they should tell that to the physician. My child won't do well if you do that.
Mm-hmm.
Yeah.
Mm-hmm. Do you have any resources that you'd like to share? Anything that you give to parents or websites or anything that you'd recommend?
So, what I have found is that most parents, by the time they come to me, have their own resources and their own websites that they like.
Mm-hmm.
I don't have any preference. I find that parents often have joined Facebook groups and the like, parent support groups, and they often have more knowledge than I do about what's going on and what's available. So I don't know if that answers your question.
It does. I think so.
Yeah.
Sometimes, we'll put the health guidelines and some of those kind of things which parents can use for advocacy purposes. And I think we might have to make a vocabulary page for this episode.
Yeah, I was just thinking that. Yeah.
Yeah, I have to make one.
Definitely. Yeah. And there's some great, like the National Down Syndrome Society's website does a good job of outlining some of the vision issues, and they do a good job of parent-friendly language explaining some of these things. So we can put some links to those kind of things as well.
Yeah, that's great. I mean, so there's one resource that's going to be available very soon on March the 20th in recognition of World Down Syndrome Day. The World Society of Pediatric Ophthalmology and Strabismus is doing a webinar about the ocular features that affect Down syndrome. And that will be available to anybody on the WSPOS YouTube channel.
Right.
And in fact, 2 weekends ago, it's available there if you go now. There was a webinar about strabismus surgery in developmentally delayed children and adults, and there was a whole section on children with Down syndrome and what to look out for and what to do.
Fantastic.
Great.
We'll put those on there. Absolutely.
Yeah.
Well, thank you so much. We hugely appreciate your time today. It's been very illuminating. I enjoyed it a lot.
Learned a lot.
I think for a minute there, Marla, you were trying to imitate my English accent.
I have an English husband.
Oh, okay.
I'm hopeless.
Hey,
Yeah.
You have an English husband, eh?
Yeah, I do.
Oh, there we go. So thank you so much, Dr. Nischal. We appreciate it. We learned a lot. I know that our listeners will learn a lot and kind of get them a little bit more empowered and informed. So we appreciate your time.
Thank you very much for inviting me. It's been an honor and a real pleasure. Thank you.
Thank you.